My name is Sandro Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. On behalf of our school, welcome to today's public health conversation. Before we begin, I would like to thank our school's Center for Health Law, Ethics, and Human Rights for presenting this event. Thank you also to the Dean's Office and to our marketing and communications team for putting this event together. These events are meant as spaces where we come together as a community to engage with issues that matter most for health. Today's conversation is particularly special. It is our annual Cathy Shine lecture. Cathy Shine was a remarkable woman who turned an experience of trauma into a legacy of better health for others. Restrained against her will while in the hospital recovering from an asthma attack, she became an author and advocate for patients' rights. Before her death in 1992, she wrote a book on race-based discrimination in criminal justice proceedings, published by the Sentencing Project. Her work connected her with Professor George Annis, the director of our Center for Health Law, Ethics, and Human Rights. Professor Annis would cite her experience while arguing in the New England Journal of Medicine for the right of patients to refuse restraints. Cathy Shine's legacy continues to inform the conversation about protecting the health and human rights of patients. We are grateful to the Shine family for helping us establish this lecture to help continue this conversation. I'm now going to turn the event over to today's moderator, the intellectual architect of this event, Professor George Annis. Professor Annis is the William Fairfield Warren Distinguished Professor of Health Law, Ethics, and Human Rights at our school. He will introduce today's speaker, Sheri Fink. Dr. Fink could not be with us live today as her current work has her traveling across the globe, but she provided recording of her remarks. Professor Annis will frame the conversation. George, over to you.
Thank you, Dean Galea. It's a pleasure to host this year's Cathy Shine lecture, the noted New York Times reporter, author, and filmmaker, Dr. Sheri Fink. Dr. Fink got both her MD degree and her PhD degree from Stanford University. She's perhaps best well known for her article in the New York Times Magazine on decision-making in Memorial Hospital during Hurricane Katrina, for which she won the Pulitzer Prize for investigative reporting. She later expanded her reporting into a best-selling book, 5 Days at Memorial, which I just happen to have a copy of here, which I highly commend to you. And it remains disturbingly up to date in portraying complicated medical decision-making under stress and resource shortages. She has also reported on other disasters, including war, Superstorm Sandy, Ebola, the Haitian earthquakes, and most recently, of course, the COVID pandemic, including articles on treatment decisions in safety net hospitals in New York and Los Angeles, and as co-creator of a Netflix documentary series, Pandemic: How to Prevent an Outbreak, which was released the same month that the pandemic hit us all. Her presentation today, which had to be taped, as the dean has told you, is on triage, ethics, and allocation, making meaning from crises. Dr. Fink.
Well, thank you so much for that kind introduction. I'm assuming it's kind because we're actually on a recording here for the Shine lecture today, and I'm only sorry that I couldn't join you all in person live, but I know that I really appreciate the invitation from Dr. Annis, and clearly there are experts on this topic at the school, Dr. Annis, Dr. Crosby, others. So it's a great honor to be joining you today and to talk about this really important issue that I think we have more insights into with every crisis, but certainly the COVID crisis has given us a new appreciation for all the issues that can come up in healthcare and can affect patients and their rights. So it's a pleasure to be with you today. And we will start with a little bit of a presentation that are kind of a couple of case studies that emphasize these issues of triage that can allocation of resources that can come up in a variety of crises. And I just wanted to start out, I know a lot of you are students watching this, and it's been a tough time. And just to remember, you know, sadly, unfortunately, there are many crises, and you are not alone in going through a difficult period. Hopefully, it will be getting better for many people soon. But I think one of the keys to getting through a tough time that the experts tell us is making meaning from crises. And so we're going to talk about some upsetting case studies. You've all been through a difficult couple of years. And so thinking about how you can make meaning out of that can, I think, be very helpful, sort of reflecting on the tough times and coming through with something that you want to take out of them. And so that's really the spirit in which I share these stories with you, which like, Cathy Shine's story, something awful and tragic happens, but then you try to make some meaning out of it or something good to come out of it. And so that's the spirit in which I share these stories. So just to give you a little bit of an orientation to the main case study today, this is just a picture of part of a hospital that was in New York City in 2012 when we had Superstorm Sandy and the East River of New York kind of flooded into the basement of a hospital, a major public hospital, Bellevue Hospital, and the water was rising in the basement and the power was in danger of going out. And so the head of the intensive care unit was called to the hospital command center and basically told that they figured that they were going to lose most of the power on her intensive care unit, which I believe had around 50 patients at that time. And you can, think about an ICU, and those of you who have medical backgrounds, or if you've ever been in a modern hospital intensive care unit, it's all about technology. And she was basically told, like, we think we can get 6 outlets working. And you can see here, there's a power source from a neighboring building, and they had jerry-rigged some power lines to 6 different outlets. And basically, like, those are the outlets that you can have for those 50 intensive care unit patients. And I just want you to start by kind of just thinking about that. How do health professionals make decisions like this when there's a crisis and you have the perception that the resources that you need, that you want to give patients, might not be enough? And of course, there are places in the world that deal with that situation every day. And sometimes a crisis like a hurricane or a pandemic can really bring those issues of resources into the forefront and make us think about them, as we probably should be all the time. So maybe think about, how would you make that decision? Which of the patients should get the power source to the machine that might be supporting their life? So we'll come back to this at the end. But this is a very wordy slide, but there won't be many of them. Mostly they'll just be pictures. But basically, it's just to emphasize that a range of crises in healthcare can cause these challenges to medical ethics, and that might influence what a patient wants versus what they actually get in terms of medical care. So there can be this issue of, how do you decide, that we just talked about, the resources allocation. And then there are issues about resource sharing. Sometimes patients need to be transferred from place to place. How do you decide about that issue? Sometimes medical professionals themselves often might be in a position of danger. So where's that? We see now the targeting of healthcare institutions in wartime, which has been a problem for many years in many contexts, a horrific problem. But what if the healthcare providers have to decide between their own safety and caring for patients, their duty under medical ethics? Magnification of disparities. We've seen that there are different outcomes from COVID, for example, in different groups, in particular in groups that tend to be disadvantaged in healthcare in the beginning. So at baseline, there are issues of, does the community come together and support? And we see wonderful displays of people stepping up and citizens being first responders in many ways, saving lives in a crisis. But sometimes there can also be tensions, and the opposite can happen. People are looking out for their own needs or becoming fearful of the other. And often we don't think of the public and all of us as, whatever our training or our backgrounds, as essential people in a crisis. And this certainly has to be acknowledged that we all have a role in ensuring and promoting the best possible health in a time of crisis. And certainly a pandemic has reminded us that if we all play our part, people will be healthier, other people will be healthier. If we wear our own mask, it can help somebody else. Crises can bring up these conflicts between different ethical principles that you might have learned about in your bioethics classes. So autonomy, that patient, wanting certain things versus this idea of justice and the sharing of resources when there might not be enough for everybody to get what they would prefer. Sometimes these ethical duties that we learn are all duties in bioethics. In fact, sometimes they can conflict in a time of crisis, and that makes very difficult decisions. End of life often is an issue, conundrums around that in crises. And then this failure to plan, I'm rolling my eyes because we're in one of those modes where our attention starts to drift. We just came through a crisis of, we're not through, but I think many people in many parts of the world feel that COVID is over, or they want COVID to be over, and how much attention is being paid in terms of what it exposed about the vulnerabilities and the things that really need to be addressed. And will those investments be made? That's always the question after a crisis. So all of these have relevance to our subject today. So I want to just tell you a story, basically, and this is Memorial Medical Center, which was a prominent community hospital in New Orleans, and you're seeing an overhead video of it now, which was taken after the levees failed after Hurricane Katrina in 2005, which just flooded this very important American city. And the water surrounded this hospital, and the hospital had a vulnerability that many American hospitals unfortunately have had, which is that it was in a flood zone, but it wasn't, its electrical system was not protected against the effects of flooding. And in fact, just like that hospital in New York, it was in danger of losing power. And in fact, as the waters rose, helicopters started to arrive. And you can see a helicopter like this size could take 1 or 2 patients, but there were about 250 patients here and about 2,000 people in this hospital complex when the water started to go up. And the big triage question here was which people to send out on those helicopters when they knew that all power could fail at any moment. Basically, the city power was out, but the backup generators were going to be endangered by the floodwaters rising. And so the backup generator system. So I just want to sort of, as you think about, what would you do, or how would you make this decision, just you as a member of a society, who has a right to have values and thoughts about this issue, as we all might. So would you be interested in getting the very vulnerable neonates out? And this is a nurse's husband showing that wonderful side of humanity, supporting a little neonate in this crisis. So would you want to get them out? There was a neonatal intensive care unit. And then there were people like this. This is just the garage, top of the garage, just below that helipad. And you can see there were older adults who were very dependent. There were, would you want to move some of them? Some of them might rely on power sources. There were all sorts of people who had come to shelter at the hospital. You can see there were children who might be vulnerable, even if they weren't, vulnerable to the actual power outage, but the mental stress. You had people boating up to the hospital asking to come in. And so this raised a question of, when does a hospital stop being a hospital? Because there were debates about whether to let people in versus kind of push them along, and fears over whether it was safe, the hospital security versus, were they actually not in a position to help these people? And then you had the health staff themselves. Maybe some of you think, well, we will need them after a disaster. So some of them might have had chronic illnesses or been very vulnerable to heat. It was starting to get very hot in the hospital because even on backup power, they had not invested in generator systems that could keep the air conditioning running. So how do you make these decisions? How did this healthcare staff make the decisions? Well, they had not really thought about it in advance. And I think until Hurricane Katrina, these issues of triage weren't thought about so much in like a regular American hospital. Maybe it hadn't been thought about since, some of our doctors who had worked in military situations. But so they kind of got together and made the best decisions they could in the moment. Oh, I forgot to mention there were pets as well. And some people were worried about getting them out too. So what actually happened here was that they got some of the dialysis patients out and more ambulatory patients out on these high water trucks before the waters got too high that it became impassable. And dialysis patients, of course, so when you think about, so how do you, what's the ethical framework for making a decision like that? Or how could you frame it in different sort of ethical terms? And so one might be, you want to think about who needs the resource that you're about to lose. So clearly dialysis patients, if they don't get this life-saving treatment that substitutes for the work of the kidneys that have failed, they could be in real danger. So the idea was get some of them out. And then for those of you who were cheering for the babies, they decided to prioritize them first. And there's this question of whether, well, how, can you factor age in? Should you factor age in? This became a huge debate at the time of COVID, actually, when it came to the rationing of ventilators, which was like an early scenario that was faced in Europe and in Italy when there were more people who needed that resource, intensive care and critical care. And certainly similar situations have happened around the world, even currently in some places now having COVID surges. And so that question of whether age can be used or not, and there are different ethical arguments, some that would support that, like the fair innings principle, which is the idea we all want to live as many innings of life as possible, versus so younger people haven't had as many innings, so you could argue they deserve to be prioritized for a life-saving resource, versus other arguments about the investment of society in older people, or how much they have given of themselves. So the value of older people and wisdom, and just the fact that their lives matter as well. So lots of different considerations here. And I'm sure if we would open this up and we were live together, we could have an interesting debate, because we all might have different values around that. And I think the question may then become, is there a way to make these decisions in a more, the decision-making process itself more just, more inclusive, more transparent, and more open. And to me, after studying these issues for many years, that's kind of where I've come down in terms of, at least having an informed process, at least having input from people who may have different value sets, and not just assuming that doctors can just make this decision on behalf of, in a way that reflects all of the values of the society that of the patients that they're treating. Because when you do open up these discussions, you find out that particular groups of people, maybe professionals who've gone through schooling or have a particular socioeconomic status, or from a city versus from a rural area, and whatnot, we all might have different ways of looking at this. And so it is important to make the process more just, even if we wouldn't all agree on these very life and death decisions. And a good example of that would be like the vaccine allocation, when the COVID vaccines were first coming out, and there was a fairly robust process of decision making around like how they should be allocated, because you could imagine that also has life and in any case. So you're seeing a picture here now of another aspect of the decision making here, which was that they designated a certain certain group of patients to go last very early on in this crisis. And you can see this gentleman actually has a 3 written on his hospital gown. If you look really closely, he's also lying on the top floor of the parking garage just below that helipad, and a nurse is waving a piece of cardboard over him to make him feel a little breeze. And in fact, they decided that on behalf of patients, without really asking them, but out of just, and again, we need to think about, this was a crisis, they were doing the best they could. They decided that patients who had so-called do not resuscitate orders should go last. And these, when I asked some of the doctors, I spent many years researching this, it became a book called 5 Days at Memorial. So I'm sort of summarizing what's in that book. And when I spoke to the individuals who were involved, and here the decision making was just a small group of doctors got together and kind of decided. They didn't think it was going to make a big deal, make a big difference, because they figured we'll all get rescued soon. So, you know, if we put these patients for last, it's, you know, not going to have so much effect. But the patients with do not resuscitate orders, one doctor said, well, I figured if a patient had a DNR order, that they would have least to lose compared with everybody else, because they probably had a terminal or irreversible condition. So that is a value judgment of a doctor being placed on that patient. So that may or may not be what that patient wanted. And sort of, you know, maybe that patient only did have a short amount of time left, but their daughter was getting married, or, you know, in other words, there could be value to that potentially smaller amount of life left. That means a lot to that patient or their family. So just pointing out, you know, there's all different ways to look at this. Another doctor said, well, I figured that someone with a do not resuscitate order did not want extraordinary measures being used to save their life. And in this case, a ride on a helicopter out would be an extraordinary measure. So they were actually maybe trying to respect that patient's wishes, that patient autonomy, but doing it in a making an assumption. And for what it's worth, and again, it's not, you know, I feel like we have to have a lot of compassion for the people in this situation, but when this was looked at by ethicists later, they did sort of say, or some groups of experts came out later and just said, like, in the future, using a do not resuscitate order as a triage criterion, as a not rescue, isn't wise necessarily, because it may not correlate with what you think it will. And also people have a hard enough time trusting in sort of end of life planning is hard, especially for Americans. And therefore, if it's used in a way, if a do not resuscitate order is used in a way in which the patient didn't want it to be used, that could lead to a loss of trust. So I'm spending a lot of time in this little, you know, kind of crucial decision making moment here, because I think it does really reflect our theme today about, you know, what the patient wants versus what actually happens sometimes in a crisis. And however, it is possible to get more input, and there have been other crises where there has been actually an attempt to take patient wishes into account, even in an extraordinary moment of you know, like an urgent emergency. So I don't want to leave the thought that it can't be done. In fact, there are ways to attempt to get that. So, and then there was another ethical decision making point here, which was, as the days passed, the power did fail. It got very, very hot, as I said, and then the helicopter stopped coming for a while, all but stopped coming. And some patients started to die. A lot of their care had been discontinued on the thought that they would be rescued quickly, and the rescues really slowed down. And there was a debate about what to do for the patients who the doctors felt would not make it, the doctors and nurses. And this doctor, one of the more senior physicians, a pulmonologist, felt that they should be given medicine to hasten their deaths. And he felt that this was the ethical thing to do. Again, not asking the patients, but believing that they wouldn't make it and that this is what they would want. Whereas others at the hospital, including one of the younger doctors, Dr. King here, said, this is not ethical, this isn't what we're supposed to do, and there are other options here. We're not being bombed, we're not being shelled, we don't have to run for our lives. We can actually keep people comfortable, but not intentionally hasten their deaths, which crosses an ethical line. And this became a big deal. I'm going to show you an upsetting photo next, which is, this was all of the bodies found at this hospital they had sort of transformed the chapel into a morgue, essentially, respectfully placed the patients there, but many patients were found to have died. And there was an investigation launched because some of the staff disagreed with what they had perceived had happened, which is they perceived that a number of patients' deaths were intentionally hastened by the healthcare staff. And it became a big case. One of the more notable patient deaths was of Emmit Everett, who had been, according to the healthcare team taking care of him, awake and alert and asking, when are we going to rock and roll? He wanted to be rescued. He expressed that, but he was morbidly obese. He had had a spinal cord stroke. He couldn't walk. He couldn't get down the stairs. There were no working elevators. And the people who I interviewed, as I pieced together what happened here, said, we didn't know how we could get him out. And he was one of about 24 patients, nearly 24 patients who were found to have died in a short period of time, a few days into this crisis, with either morphine or Versed, which is a fast-acting sedative, or a combination of the two, in their bodies. And so there was an investigation launched, and in fact, and this is his family, who felt his life had value, and they wanted him home. So the Attorney General here of the state of Louisiana arrested 2 healthcare professionals. He's holding up 2 fingers to talk about those 2 drugs. And it became a big debate over, whether he arrested them on accusations of second-degree murder. And the doctor and 2 nurses who were arrested have always proclaimed their innocence and said they were just doing their best to keep patients comfortable. This is the coroner who had to decide whether to classify these as medical homicides, which simply means that the action of one individual caused the death of another. And he's probably talking about something totally different, but to me, this is, every time I interviewed him, he would throw his hands up and, talk about not wanting to give the city a black eye by, saying that these were homicides. And there was a lot of support from the peers of these health professionals who felt that they didn't know what happened, and they just assumed these people had stayed, they had sterling reputations and had done their best. And this is the assistant district attorney with the district attorney at the podium. The ADA, this young man, had to prosecute the case bring it to a grand jury to see if there would be an indictment. He told me, I felt like I was applying the law to a war zone. But as we should be reminded, especially now, war zones do have laws. There are laws of war, and this wasn't a war zone, in fact. And in fact, there are laws and ethical tenets in medicine that typically, in general, crossing that line to intentionally hasten death is typically not okay, both in an ethical sense and in a legal sense. And so there are many debates to this day about this case, and I won't spoil and tell you what happened in case you want to learn more about it. But just to say, I want to end with, as we get closer to closing here, I want to just talk about some positive things, which is that, yes, this lecture is about patients' rights and the instances where patients' wishes are not necessarily followed and where tragic outcomes and deaths can happen. But also we should remember that in many times healthcare providers they do care a lot, and this is just some examples of how hard people worked even in this crisis to get people through a hole in the wall into the, up to the helipad. This is another man who was equally obese who did get saved at this hospital. And everybody who was saved through the helicopter route was carried up rickety flights of steps at some risk to the staff. And so I want to just go back before we end to that initial dilemma about the 6 power outlets in the intensive care unit. And maybe you've thought about how you would choose which patients, or how impossible it would be to choose. And so the doctor in charge here said she had actually heard about the Katrina case. And so she said, she started to think about, well, how would I want to look back on this? Like, what do I want the headlines tomorrow to be? And how will I be able to explain to the public how I made this choice? And so she decided it was not a choice for just herself, but a committee of people, and people who did not have a patient on that intensive care unit because they would have the duty to their own patients. And they used some sort of scoring system, and they tried to just come up with a method that would help them decide on some of the patients who could use those resources and who were likely to benefit from them. And then they kind of switched around the beds and got this all ready. And then, as I want to really emphasize, because a lot of times we can think about these very interesting ethical conundrums or these resource allocation conundrums, but the real solution is to get more resources, obviously. Then you don't have to have a tragic consequence. You don't have to decide. And that's exactly what somebody had the brilliant idea that actually what was going to cause the power outage was the fuel pumps weren't going to work and get the fuel up to the generators, which were on a high floor. And so they formed a human chain, and they brought fuel up and they hand fueled the generators. So they avoided the problem. They kept partial power going, and they were able to actually even save somebody who was morbidly obese, even I think the same size or larger than the patient who died at Memorial, Emmit Everett, and get one elevator working and get him out. He was one of the last patients out of Bellevue. And so so there is a sort of a lesson here, which is that sometimes if you think outside the box and you're creative, you can sometimes find ways to expand your resources, and that's always a better option if you can. So I want to just summarize this by saying, prepare to, but also prepare to be flexible. We do need to invest in preparedness, but we need to expect that we will be surprised, as we have been for the last 2 years plus with COVID. Sharing that burden of decision making, thinking about having a more inclusive processes, and acting with an eye toward tomorrow, while also being really kind to yourself, because crises, nobody's perfect, and they never go perfectly well. This is a very long slide, but I'll just say that it sort of makes the points that we did earlier, which is that these decisions, that there needs to be more input in from a broader section of society. And so I just want to end by just like giving a nod to the last 2 years, because that was many, many years ago, and sadly still very relevant to some of the conundrums that we faced with COVID and that are still being faced in some countries. And this is just a picture from almost exactly this time in 2020, 2 years ago, when New York City had a huge surge, the very first COVID surge in New York, and I think it was in the US, the big surge. And this was a hospital where I spent quite a bit of time with a photographer, a brilliant photographer, Victor Blue, who took this photograph. And we saw, again, just, not ideal circumstances for patients, for patient care. We now know that, in fact, during COVID surges, the mortality would rise of COVID itself. So just the fact that hospitals would become stressed, they would, that the patients were not getting equal care. And sometimes, and this is a hospital that is a safety net hospital, and there were disparities in outcomes sometimes that we've seen that have been documented. And then there had been some triage protocols that had been developed after Katrina, after some other, with the realization that there could be a respiratory pandemic, much as we've seen, and that we wouldn't necessarily have all the resources to treat patients. And when these protocols that had been developed by some, health professionals, mostly in small groups, doing their best and trying to follow ethical principles, but when the public became more aware of them, when it looked like there would be rationing instances, all sorts of issues have arisen. And so this is just an article I wrote if you want to look it up, but it just outlines a lot of some of the complications of having these protocols, when it's very hard sometimes to predict who will benefit. And this is another wordy slide, but basically a lot of these protocols were initially created to triage ventilators, but in COVID we found out that even with this almost the exact scenario that was thought about, big respiratory pandemic and big stress on intensive care units, that in fact it was like other things that became in short supply, and that it's not easy to just have one principle for how you would triage or allocate that when those became short, because there were different considerations, different groups of people, and you couldn't just have like one score. And so that idea of being flexible and being alive to the possibility that your original scoring system might not be adequate to the actual conditions, I think that's a really important takeaway. So again, just in general, as we think about crises, what are the bottom lines? And one of them is that you always need to be reassessing and looking at your resources and your needs and trying to make sure that they, in healthcare especially, that you're looking at the actual situation. And that is hard to do in a crisis, to sort of step back and take a deep breath and really assess what are the issues. And we've talked about a lot of these other things, so hopefully while I'm chatting, you've been able to look through them. But moral injury is the other part, and just all of the ways in which COVID has stressed people in healthcare. And some of you may have been on the front lines in various ways. We've all been through something, but people who've had to be in a position of providing care that is not the care that they know how to provide, that is extremely stressful. And I just wish everybody who's gone through that to have the peace of knowing that you did your best, and that these were impossible positions to be in. And so that it's very difficult. And on the patient rights side, I think, we have to grapple a lot with the fact that a lot of patients were not able to be with family members or caregivers, that was a decision made across the board in many places. And that is a very disturbing one. I think we need to think a lot more about the effects of that as well. And so just ending with some photos from these various time in different intensive care units and COVID surges in different places with these brilliant photographers, and just getting a sense here of how much, how many resources are needed to respond in a COVID surge. And then these were some photos of instances and projects where we were pointing out the disparities in outcomes for different patients. This is an intensive care unit in Houston, and like in many parts of the US, where there was a disparate impact on the Hispanic and Latinx population. And so we looked at one hallway on this ICU, and just about everybody was within that group, which was disproportionate to their numbers in the community. And that was notable. And this nurse who said, they all look like my sister and my mom and my brother. Just reminding us that it's human beings who we've lost, and that patients aren't just numbers. These numbers of deaths are staggering, 6 million around the world from COVID, but each of them has a family who loves them and care for them, and each of them had value in their lives, like Cathy Shine. So all of their lives were important. And I want to end, as I promised, on a more positive side. And this is just that, healthcare professionals did work really, really, really hard, and lives were saved. And you can see this woman who nearly died when she was able to text her family just how thrilled they were. And then just showing you some photos from around the world where healthcare resources on a normal day are not what they are in the US, and how the triage decisions there were very difficult. And I'm going to end with a little video from, this is a massive hospital. You're now seeing images from China of some of these huge hospitals being built in China, mostly to help isolate patients and protect others in the community. But this was one in South Africa during the surge of the beta variant, which was very bad there. And this is a former car factory where patients who were quite sick were brought here because the hospitals were really full. And it was a very difficult situation. There were very few resources in terms of like oxygen and other measures to support breathing. With beta, it was mostly a very bad pneumonia that people would die of. And so there were horrible, needless deaths. I watched a school teacher die, a young woman with children. And but as the photographer I was with that day, as we left, we heard this sound coming from this part of the facility. And so we walked back, and I want to share with you what we came to. So never give up is their message. Samantha Reinders was the photographer who took some of the photos you just saw. And so I'll leave you with that, and with a great respect for all of the people in healthcare and all of you who care about public health. And thank you for the work that you do. And I wish everybody the best. And thank you so much for listening. And this is a doctor celebrating when one of her patients was doing a little bit better. Again, reminding us of the positives. Thanks. So many years later, what are the issues that that were raised there, and like sort of how have they developed? I think that's the question. And one thing that has changed, I think, number one, is that Katrina really woke people up in the medical community to the potential effect of a variety of, disasters and crisis situations on patient well-being, on hospital functioning. And so it was raised in terms of being a priority a little bit more in terms of the planning process. But it's interesting and it's instructive in terms of like COVID and what will we, how will we honor all of the people we lost? Will we make some investments that address some of the problems that led to such a great toll of, death and suffering and long-term health issues? And with Katrina, which was that example, that story was on the news, and the death toll from Hurricane Katrina really shocked Americans at that time. For those of you who were too young to actually remember it yourselves. And even with that, it took many, many years for there was an initiative to try to require just a basic emergency preparedness for all healthcare providers. So not just hospitals, which already had some requirements, but, dialysis centers and, nursing facilities and a range, there's a whole range of different healthcare providers that most of them do get some government funding through payments through Medicare and Medicaid. And so there was an initiative to try to create a rule that would require some basic preparedness, like, doing a drill once a year or having certain emergency plans, not too hefty of requirements. And that took so many years. I think it's only been 5 years that it's actually been in place. Like it finally got through the system. It took a lot of time because it was considered an unfunded mandate. There wasn't, federal funding to support providers to implement these things. And so it's just a reminder that, yes, these issues of preparedness are, with us all the time, that, they can have life and death consequences, and they can really affect patient care and the patient's ability to get the care that they need and that they want. So I think that's one of the lessons from those many years ago, is that, take it to, and our health system has really struggled with the pandemic, and we've seen where the vulnerabilities are. So the question is, how do we make those investments and try to, use creative thinking and decide where our values are to try to promote human health and human life. And I guess it's just a decision. It's another triage decision as to how much do we invest in these types of things, and where do we put our resources as a society. And I think there's, debate about that, and it's really not clear what we'll come out with in the end. So there are so many answers to that question of how do we do better next time? And I think the first thing is to realize that we're not through this crisis. And so lofty plans for the next pandemic, really, in some ways, that it's if we can't fix our response or improve our response to the current one, then that's a problem, and that means there's maybe not so much hope for the next time. So probably we need to look at our situation right now, and there would be many ways to answer this question. There will be many reports written, I'm sure, and things looked at. But one thing that just jumps to my mind from spending a lot of time in hospitals during the pandemic is just the health workforce and all of the strains that have been on the health workforce, and the shortages of certain types of providers, and also just the untenable situations that they were put in. So I think that's one area of focus that would be really important. And in terms of others, I think maybe we step back and we look at healthcare and sort of health provided in hospitals as a very last step. But there is something very big we need to look at just right at that front end, which is how we together in our various parts of the US and various communities, how can we all do better at coming together and protecting the people who need to be protected, and ourselves in a crisis, and how do we unify more, I suppose, in the service of protecting human health and human life. Why did we make different choices, and why have we had so many splits and continue to have divisions in terms of how we look at this? So I think these are just important questions. Another one would be information and expertise in healthcare and public health, and why there's such a lack of trust in science and data, and loss of public trust in public health officials, and even in physicians. I remember speaking with I was out west during a big COVID surge some months ago, and it was an area where there hadn't been much interest in getting vaccinated. It was very low vaccination coverage for COVID, and many people were dying. The intensive care units were full. All sorts of other healthcare wasn't being provided because the hospitals were so overwhelmed with COVID patients. So a lot of people, even if they had taken a vaccine, or whether or not they had, they couldn't get care for other things. And I remember doctors just saying that they live in this community too, and there were patients that they've had for years who they treated, who trust them for all sorts of things, but there was not a trust in the advice around the utility of the vaccine. So why was that? That is just such an interesting and difficult question, because it's not about what a politician says or what the media says, but this is this individual who knows something about this, and who you've trusted for years, and who lives right there with you in your community. So why was there that loss of trust? So I could go on and on. There would be many things that we need to understand more and learn more from coming out of this that affected patients' lives, and certainly the toll of human suffering from this pandemic. So healthcare inequities are something that are with us all the time in our society and across different countries. There is different access to the means to which people have access to being able to live healthy lives and have access to medical care that they might need. And so again, as I mentioned at the beginning, that these times of crisis can sometimes bring them into relief. And so they're not just this background noise that nobody pays attention to, or very few people pay attention to, but in fact, they get more attention, and we become more aware of them more broadly. And so what we saw in Hurricane Katrina, for example, was that a lot of the patients who died, for example, at this hospital were people with who were older, who had multiple chronic health conditions, who had, like Mr. Everett, a physical disability. And so we need to be aware of how these individuals and groups of people can be disadvantaged. And their data, there are probably definitely people at your school of public health who are studying these issues and have documented differences in access to healthcare and outcomes in different groups along socioeconomic and racial and sort of ableist, ableist and disability sort of discrimination types of lines. And so there are many ways in which these disparities have they're very evident. There's a lot of data and evidence around them, and that they can get magnified in crises. And so another example, not just Hurricane Katrina, but also certainly with COVID, there are racial disparities in outcomes. There were differences in healthcare provided by in different areas of the country, in different hospitals. Colleagues and I wrote an article that just analyzed outcomes within New York City and found differences. So in other words, it's a real issue, and perhaps we can take the evidence and the sort of very drastic differences in the mortality from COVID and be outraged by that and want to do something to solve it. And I think maybe that's a great way to end, since again, many of you are students, and one of the pieces of advice that us older people always love to give advice to younger people, but I feel like if you can harness your outrage, and there's so many different reasons to be outraged, I suppose, but that's a good thing to use to sort of send you in a certain direction in life. In other words, what are the problems that really make you uncomfortable and that you want to solve, and maybe apply your energies in that direction. And for those of you involved in the public health community and in this audience, I think there are many to choose from, and this certainly would be one of them. It's just such a, sometimes there's this gap between the knowledge we have and what we writ large do about it. So where can that, where can you plug that gap between what we know to be true and these disparities and how objectionable they are, and then how they're actually solved in a way that really affects people's lives. So I'll just leave it with that. Harness your outrage and just keep going, and great respect for those of you who dedicated your lives to trying to improve human health. Thank you for having me today. It's been nice to join you virtually.
Please join me in thanking Dr. Fink. One of the, I thought Dr. Fink's comments really were terrific in illuminating some really difficult challenges that we've dealt with in the context of COVID. And I've said this before in many circumstances, that nothing can redeem the tragedy that is COVID. I think Dr. Fink did a wonderful job of highlighting how COVID, we're dealing with hundreds of thousands of deaths, we're dealing with hundreds of thousands of people. But certainly one of the responsibilities we have is to honor this tragedy by learning from it. And I think Dr. Fink is leading the way in thinking about these particular issues, making sure that we learn from the moment. Thank you, Dr. Fink. Thank you, all of you, for being a part of this conversation. Thank you, Professor Annis, and our colleagues at the Center for Health Law, Ethics, and Human Rights for arranging this. Everybody have a good afternoon, have a good evening, take good care. We'll see you at our next public health conversation.